Hey, Tara, how's it going?
Hey, Danielle. So glad I caught you. I have a favor to ask. I am starting my own podcast.
What?
Yeah, I am. I've been thinking about it for a while, and I'm going to do it. Guess what the podcast is about?
I mean, I hope it's not about fixing cars because I can't help you very much with that. If it's got something to do with family medicine and primary care, I'm probably pretty good for it.
Yes, it is about primary care. And I wonder if you would be my first guest.
Are you serious? Absolutely. I'm honored to be your first guest. Thank you for inviting me. What's it called?
It's called Primary Focus.
Count me in.
Welcome to Primary Focus. I'm Dr. Tara Kiran. I'm a family doctor and a researcher who is passionate about building a stronger, more equitable primary care system in Canada. I'm the Fidani Chair in Improvement and Innovation at the University of Toronto, and I practice at St. Michael's Hospital, Unity Health Toronto, where I'm also a scientist at the MAP Centre for Urban Health Solutions. In my research and practice, I try to find and test solutions to make healthcare more inclusive and effective. Back in 2022, I launched Our Care, a national initiative to co-create a blueprint for primary care reform together with patients and the public. And now I'm launching this podcast to spark a national conversation about the current primary care crisis in Canada and how we're going to solve it. For more on this podcast and our mission, click over and listen to the trailer. So for this episode, I've asked my friend and colleague, she's actually also my boss, Dr. Danielle Martin, to help me catch you up on how primary care works in this country and map out the current crisis we're facing. Now, if you've never met her before, let me introduce you to Danielle. She's the kind of person who can make you feel inspired just by hearing about her work. I mean, she was the head of our National Medical Students Association and the provincial residency organization in Ontario. She founded Canadian Doctors for Medicare. She spent 8 years as a senior hospital executive at Women's College Hospital. And of course, in 2017, she wrote a book, Better Now, 6 Big Ideas to Improve Healthcare for All Canadians. Today, she's the chair of Family and Community Medicine at the University of Toronto, the largest department of family medicine in the world. And she's still a practicing family doctor and a mentor to many aspiring young leaders. She is a bold thinker, an unapologetic champion of access to care for all, and I'm proud to call her a friend. So today, Danielle and I are talking about how healthcare in Canada is organized, how it's funded and delivered, and who, if anyone, is being held accountable for a current crisis in primary care. Oh, and I just happened to be chatting with Danielle just hours after the Ontario government announced $1.8 billion for primary care. Their goal? To connect all Ontarians with a family doctor or primary care team in the next 4 years. We'll definitely be talking more about that in a future episode. Big announcement today, so
Woo-wee.
Yeah.
Not bad.
Yeah, it's pretty amazing. So good day for primary care in Ontario.
I'm pretty happy.
Going to be so much good work that we can do now over the next, I think, year or 2 or 4. So thanks for joining me, Danielle, for this first episode. I'm excited to have you on. We wanted to start off our podcast setting the ground level. What is primary care all about? What is it like in Canada, where we are right now? What are some of the deep issues that we're facing and where can we go? And I thought, who better to ask all these questions to than you? So I guess to start, Danielle, I wonder, can you define for me, what is primary care?
The easiest way to think about it really is that primary care is the front door to the health system. It's the place where people enter the care that they need. It's a place where you have a relationship over time with a clinician, often a family doctor, but not always a family doctor. It could be another healthcare professional where they know you, where you feel seen as a whole person. And it becomes also the entry point into other healthcare services, whether that's imaging tests or lab tests or specialist interactions, or importantly, community supports, other kinds of social supports that might be required for health. It's also the place, hopefully, from which we can engage with not just individual people, but groups and communities to think about how Do we create healthier environments more broadly? It is the kind of first entry point into healthcare, and therefore it forms the foundation of health within healthcare systems. So when it works well, it can be really beautiful, and when it's not working, it can be really, really challenging for people to access the care that they need. It's also, and I know we'll talk about this more, way more expensive and way less satisfying when people have to enter the health system through places other than a strong foundation of primary care.
Yeah, you use the word foundation, and I think that's another analogy that I like to use, that it's like the foundation of a home. If the foundation starts to have cracks or there's a problem with the foundation in your home, then everything else falls apart, because it's really what's keeping that home intact. And I think what you've just gone over is what we often talk about as the 4 C's. So primary care is the place that you first go to when you need help, or first contact. It's also the place that you get continuous care, so where you can see the same person over time and who really gets to know you, as you said. And the family doctor, our primary care team, coordinates your care. And importantly, they look after the whole system, so it's comprehensive. So it's not just like the mind or the body. I mean, I think one actually misnomer a lot of the times is that people think about the things primary care or family doctors do, and they think a lot about the physical stuff. But actually, I think probably a third of what we do is actually mental health care, depression, and anxiety.
It's all of those things. And the other thing that we experience as people working in family medicine and primary care is it's all of those things at once. I was in clinic this morning with a medical student. 2 of the patients she saw, in addition to having some prevention needs, like due for an immunization and a mammogram or whatever, and also some acute needs, like my knee is bothering me, but also both of these patients had just recently been seen by a specialist and had come back to kind of decode what the specialist had recommended. And so it becomes a trusted place that people come back to, well, the specialist said I should do this, but you know me, so what do you think? Should I really take this medication that the specialist provided to me? And so it's the mental health, it's the physical health, it's, also sharing that my mom had a stroke and it's really causing me stress. And maybe that's why my blood pressure is up a little bit more. And do you think that the cardiologist understood that? And do I really need to take this additional pill or whatever it is? And so it's all of these things: mental health, physical health, social environment, family issues, all at once. And it's that kind of weaving together of those different elements that builds trust and relationship over time.
What do you think about primary care and how it's organized? Do we even have a system in Canada?
To get into this in the Canadian context, we kind of have to go way back in time to the beginnings of Canadian Medicare, when famously Tommy Douglas, then the Premier of Saskatchewan, wanted to eliminate financial barriers for people who needed healthcare. And this was on the basis of his own experience as a child. He had osteomyelitis, a very serious foot infection, and eventually was only treated because his parents agreed to have him taken on as a teaching case. But his family faced this stark reality that, of course, is today true in most of the world. The choice between medical care for your kid and, in their case, losing your farm, so paying rent or groceries or getting access to healthcare. That's a choice that people have to make all the time, all over the world. And he didn't think it was right. And he set out to fix that for the people of Saskatchewan. And first he put in place public insurance for hospitals. And then he came to want to include doctors in that. And the doctors of Saskatchewan, although many may have supported this concept, certainly organized medicine in Saskatchewan was not into it. And the doctors actually went on strike, very famous, very bitter strike, to try to preserve their right to bill patients directly for care and to bill private insurance. And in the end, they reached a compromise, what's now known as the Saskatoon Agreement, where effectively the doctors agreed that they would not bill patients for their medically necessary services. They would bill the public insurance plan, but they would remain independent practitioners. So the deal was, you're still an independent business owner. You still make your choice about how you're going to organize your clinic and your life. And hire your secretary and run your charts and do all of the ins and outs of your business as a completely independent business owner. But instead of sending the bill to the patient, you'll send your bill to the government. And that was the Saskatoon agreement that formed the basis of family medicine in Canada today. And so it continues to be based really on that model, where the defining aspect of Canadian Medicare, which is people should access care according to their need, not their ability to pay, which is a very deeply held value by Canadians. Nevertheless, our doctors are not employed by the health system. We don't have a national health service. We don't really have much of a system to speak of. We don't tell healthcare providers where they should work or what neighborhood they should work in or how many patients they should see, or, we don't offer them a pension. We don't give them benefits. They don't have paid sick leave or paid vacations or whatever. They're completely independent, but they send their bill to the government. And so I would say it's not really a system in that sense. It's an insurance plan, but it's not a well-organized system. And there are some family doctors and other folks in the health system across Canada who continue to believe that that's a good thing, that it gives us maximum independence and flexibility as healthcare providers, the ability to respond to the needs of our communities without having to kind of run everything past the government. And there's a grain of truth in that, of course, but it's also true that it means that where we see big gaps in access to care, it's very hard for government to fix those, even though the people whose taxes are paying for that care kind of expect their governments to fix it when they see a gap. So there's a mismatch between what people expect government should be able to do and what government can actually do in that space. And I think that creates some of the tensions that we see today. Here we find ourselves, it's 2025. We've got 6.5 million people, as your excellent research has shown, who don't have a family doctor or really any access to primary care in Canada. And we're trying to figure out, how do we modernize these systems to meet the needs of today in an environment where systems were not really built for that kind of system capacity building or oversight? It's a tension that kind of defines the way that primary care is set up in Canada, for better and for worse.
Yeah, for sure. I mean, I think the other thing that I think about in terms of the legacy of Medicare is that, of course, it really laid out funding for hospitals and doctors as part of that insurance plan, but not much else. And of course, in an ideal world, to keep people healthy, primary care really would include more than just doctors and hospital. It would include funding for mental health care, for dental care, for eye care, for all these things. And we heard that from people we spoke to across the country, that they felt that all those things were important for them, but that it was frustrating that they weren't covered. I mean, I think reflecting on what you say too, I guess the question that comes to me is, who is accountable? Is there anyone that's even accountable? So when 6.5 million people in Canada don't have access to primary care, is that the federal government we hold accountable? Is it the provincial governments? Is it individual doctors, the doctors' associations?
Yeah, I mean, that's the tension. And I guess I would say that the Canada Health Act, which, if you ask Canadians, they sort of expect, actually, because this value of access to care based on need, not ability to pay, is seen as a Canadian value, a defining Canadian value. I think many Canadians do kind of think it's the job of the federal government to fix these problems, because they think of healthcare as public healthcare as a Canadian thing. I understand that's I actually think it's quite beautiful that it's a Canadian value, but actually the federal government doesn't really have the levers to fix these problems on the ground. And so there is a mismatch between where we want that accountability, or we sort of intuitively feel that accountability should reside, and where the power resides. The power is sort of distributed. I think it was Tony Blair who once said, when he was Prime Minister in the UK, that he arrived in office and was pulling on the levers of power for many months before he realized they weren't attached to anything. I'm pretty sure I have that quote more or less right. And that's I think that must be what it feels like, probably, to be a federal minister of health. I wouldn't know, but you think you're pulling on these levers and they're not attached to anything.
Yeah, I think that from the public's point of view, they want access to primary care. They want a family doctor or a nurse practitioner or team who can see them on an ongoing basis, who, they can rely on and build that relationship with, the trust, and go back again and again for different parts of things that are bothering them, mental and physical. And so, yeah, I think so. We continue to have this issue of so many people in Canada not having access to primary care. Why is it that we are in this mess? What I think is absolutely a crisis. I think it's actually apt to use the word crisis, because when you have 1 in 5 people or more than that not having access to the front door of the system, I think we're in a crisis. So why is it that we're in this crisis? I obviously have my own thoughts, but I'd love to hear yours.
Yeah, I agree. It's a crisis. I've even gone so far as to call it a state of emergency.
Right.
Although I do
not the kind that the army is going to come in.
No, definitely not that kind. Not the kind where you send in the army to shovel the snow or whatever. No, yeah. But definitely it feels that acute, and our colleagues. I will say parenthetically that in the 20 years that I've been at this, I never have had so much support from my specialist colleagues as I feel right now, because, as you say, this crisis is spilling over into our emergency departments, our hospital wards, people seeing very complex patients with a lot of needs in the dermatology clinic with nobody to send them back to deal with their complex chronic illnesses. And so it's being felt in every part of the healthcare system. And it gives me no pleasure to have these conversations with specialist colleagues, but I feel like the whole system is feeling this crisis in a way that perhaps it hasn't before. Why are we here? How much time have we got? So many decisions and non-decisions have led us to this point. Everything from difficulty in recruiting new graduates to practice comprehensive family medicine in the community, the non-existence of infrastructure for interprofessional teams, the aging of the population, which includes the population of family doctors, with people retiring out and hanging up their stethoscope with these huge practices with nobody to hand them over to. The pandemic, of course, accelerated that phenomenon with people retiring from practice, including people who retired from family medicine practice in the community and yet have continued to practice medicine in other ways, like those focused practice environments that you named. And then also just like the increasing complexity of the work combined with what people are calling administrative burden or paperwork, which I have some ambivalence about how we label that work. Some of the administrative work that we do in family medicine and primary care is just like straight up our jobs, and everybody has paperwork in their jobs. Like, I live with a lawyer, everyone has email, everyone has stuff they need to fill out that they wish they didn't have to do. Everyone has administrative irritants, but the absence of good systems to deal with things like referrals to specialists, timely access to imaging, employer requirements for documentation, these things which are symptoms of underinvestment in appropriate systems of flow in healthcare, all come back to the family doctor's desk.
Yeah.
And that stuff is a recipe for burnout. I don't mind filling out somebody's disability forms, because that's the difference between a person getting income and not getting income. And I am the only person who knows enough to be able to fill out the forms for that individual to describe in detail the degree of their medical disability. That feels like a good use of my time to me, even though some of those forms are super annoying and too long. I do it. I consider it a sacred duty to do it. But I am not amused to have to re-refer the same patient 3 times to different specialists to try to get them the care that they need, because it turns out this person only sees the left foot, not the right foot, or they retired and no, we won't pass your referral along, or our wait list is too long, and so we've simply closed it to new patients, and you're tearing your hair out trying to get somebody something that they legitimately need. That's not a good use of my time. That's the kind of administrative work that leads to burnout. And so all of these things are factors. And of course, it is also true that in most Canadian provinces and territories, family doctors do earn less money than other medical specialties. That is a driving force in career choices for new graduates and existing experienced family physicians as well. If you can earn more money by doing a job where you work hard for a few weeks and then clock out and there's no ongoing responsibilities and obligations, that's hard to compete with. And all of these factors and more contribute. But I am less interested in how we got here or how hard it is than in hope. And
where it is that we need to go. I agree.
Yeah, the beauty of our jobs.
Yeah, I totally agree. I mean, at the same time, I think it's important that we understand, the issues so that we can tackle them. When we, as you know, I do a lot of quality improvement in healthcare, and we always talk about how understanding the problem is the thing that actually a lot of people don't take enough time to do. And I think we have taken the time here because I think we do have a good sense of why is it that we're in the crisis. And you named so many of the things. I kind of think about it as demand and supply. So, our demand for healthcare and for primary care has been going up. There's more patients because of growing population, and each patient takes more time because they have more complex chronic conditions and more social issues. The medical conditions are unfortunately to be expected with an aging population unless we do a really, really good job keeping people very healthy through, health promotion and prevention and exercise and whatnot. But so there's the demand side, but then there's also this, the supply side, which is I think what you spent a lot of the time talking about. And I guess just one thing I would add to the supply side, it become crystallized for me over the last little while is we have a lot fewer doctors per capita than many other peer countries. We're actually just short on doctors. And then within the doctor group, then fewer people are going into family medicine. Many people, as you mentioned, are leaving family medicine or even training in family medicine and choosing then to do something else. But this issue that we are short on doctors overall, and that is driving some of this, I think is one that I hadn't quite understood as well until more recently.
Yeah, I mean, there's been such hot debate about this. We could talk about it for a long time. What's the right number of doctors per population? I mean, of course, in Canada, there's the very particular issue around distribution, right? That many of our comparator countries don't experience with the same level of acuity.
Absolutely. So you would think we would need more, actually. And so what we see, though, in the Netherlands or Denmark, 1.6 times the number of doctors that we have. I mean, that's pretty substantial, not a small drop. And then, some people like using this analogy of family doctors being the Swiss Army knife of the healthcare system. And so, if you got a Swiss Army knife, someone who can do lots of different things, then of course they're going to be used in different ways in the healthcare system too. So, but you've pointed to so many of the other things, not enough payment and system inefficiencies and all that stuff. And also just society changing over the years. Nobody wants to work the way that people worked 30 years ago. People want to have more work-life balance and not work as many hours. But I think what was so important is that you mentioned hope and that you still love being a family doctor. And I know
I love being a family doctor. I still think it's the greatest job on earth. I can't say enough about the magic when it works, when you're doing what you feel you're there to do. I just can't imagine anything more. I say this as a person who's not especially spiritual. I do believe it's sacred. It does feel that way to me. The trust that runs both ways. And when I think about my patients who I've known for and taken care of for 20 years and the way that we relate to each other, that relationship is I do think it's actually magic. And we don't spend enough time talking about that.
Is there a story that comes to mind for you or stories that you wanted to share?
Well, I'll just share, I have one patient just because it's fresh in my mind, who I spoke to on the phone. Actually, I called her last week just to check in on her because she's older. She's got a whole bunch of medical problems. She'd come in, she'd fallen. And so I was worried and just kind of wanted to follow up. And she's pushing 80 and she's an incredibly active person. She's always taking courses at the university. I know her daughter, I know her granddaughter. We just have this beautiful relationship, and she's exactly what we all should picture when we think about healthy aging, just, an extraordinary, intellectually and physically engaged person. And I called her and she said, I was just thinking about you, wondering how your daughter's doing. Because she's known me, my daughter, who's now 15 and barely speaks to me, but only in a age appropriate kind of way. She remembers when I was pregnant.
Yeah.
And so like that way that we care for each other, and that I was thinking about her, and here she is like studying for this course that she's taking for a degree she doesn't need because she's 79 years old. And we're thinking about getting stuff in place in her home. And, it was all of the things. It was the physical stuff. It was the environmental stuff. It was the social stuff. And then it was this magic between us where I was thinking about her, but actually and I called because I was thinking about her, but she had also, for whatever reason, been thinking about me. Like, in what other job do you get that? It's a small example, but one that sticks out because that was just Wednesday in my job.
Yeah, it's truly a special thing to build a relationship with someone over time. Funnily enough, I also have patients who ask me about my children. And I think for many years, many would ask me how old my baby was. And my baby is now 11 years old. Yeah. But in their mind, the time has gone very slowly. Yeah. So they're asking me how's your baby doing? And I'm like, oh, they're 11. What? Anyway, so what you're telling me just rings so true, because it is this relationship that's not just one-sided. You're holding space, of course, and being there for patients, but there's so much that they also trust you with. It feels very special to be able to know things that they're disclosing to you that they haven't disclosed to anybody else, and to enter these private worlds actually that you wouldn't ever have privilege to, in your social life normally, to be able to be a part of something so intimate and have people trust you and help them navigate through some of those most difficult times and the most special and beautiful times in their lives too, is very special. And then, if things happen to you, they know that they're there and they ask you about it. And it's a very special thing, this relationship. The secret sauce, as you say.
Secret sauce.
We both are fans of putting more of that secret sauce into the healthcare system. And that we've talked to people across Canada for the last couple of years, and they want to see more primary care. And we've kind of pulled together everything we heard in the Our Care Standard, and really looking to that as kind of the beacon. And I wonder if you're thinking about the future and the hope, what is it that you think that we should be doing? Where should we be acting? And I know there's a lot of answers here, but maybe just, what are some of the top things you think that we need to do?
I feel there was a thing in the media just last week or 2 weeks ago where a new family doctor opened the doors to his practice in Walkerton, Ontario. And it was announced that he would be rostering 500 people. And it's January that we're doing this podcast. It was cold and snowy, and people started lining up at 2:00 in the morning outside of the Rotary Club or wherever it was that they were signing people up. And, the newspapers came and the TV cameras came to say, this is what we've come to in Canada now, that people have to line up. No, this is not a Taylor Swift concert ticket lineup. This is people lining up starting at 2 a.m. in the snow to try to get a family doctor. This is what we've come to. And then the media are interviewing people in line, and so many of these people, it's such a Canadian. I mean, first of all, the snow in and of itself made the scene so Canadian, but people saying, I'm really so overjoyed that I made it to the front of the line, and I feel like I won the lottery getting a family doctor, which should just be the right of every resident of this country. But also I'm worried because I know there are people who couldn't line up, and I feel a bit badly that maybe I took the spot of somebody who needs it more because I could line up. Mm-hmm. Such a Canadian sentiment, my neighbors worrying about who else isn't in the line, who couldn't make it to the line, and what that means for somebody else. To me, that's what Our Care is about. And the power of the work that you have done is not to think about what we need to do from the perspective of academics and health system leaders and people who study this stuff, but to think about it from the perspective of the people who use the system, the owners of the system, the public. And those folks in Walkerton understand what it's about, why it matters. That's why they lined up. They get that this is the core, the foundation, the alpha and the omega. So I think we take our cue from them. And what do we need to do? We need to put in place, of course, there are investments that are required. We need to pay for the care that people need and deserve. We underspend on primary care as a proportion of health expenditures as compared to other OECD countries. So we need to right-size the budgets. We need to put in place those interprofessional teams so that it's not a doctor-only show. And that is part of how we're going to get over the undersupply / maldistribution of physicians, is by not thinking of this as only a physician thing. You can do a lot more with a doctor when that doctor is working in a team with a pharmacist and a social worker, an addictions worker, a nurse practitioner, a physician assistant, a peer worker. You put those people together, you've got real power to take care of folks, and that's going to cost money. But also all of those infrastructure pieces that we have been talking about, I think are going to be really important, because as the diseases and the medical aspects get more complex, the system ratchets up its own complexity. And if it is the job of individual family physicians to try to navigate that complexity on our own for people, we will burn them out. And so we need those system fixes like central intake for specialty care and advanced imaging as one example that I'm quite obsessed with. But there are other examples as well. We have to begin from those principles. We have to declare the goal. I'm very happy that in Ontario, we finally declared the goal. 100% of the population, everybody, should be attached in a meaningful relationship to a primary care clinician supported by a team. That's the goal for everyone. And usually that clinician will be a family doctor, but not always. And, that's where we begin. And then there are all kinds of enabling things that we need to do and put in place.
Yeah, I totally agree with you that it starts with articulating the goal very clearly. Unfortunately, there haven't been actually as many jurisdictions doing this across Canada as I would like, but it has been the case in Ontario that they've declared the goal now. And I think they declared the goal in PEI and maybe a few other places, but declaring the goal of everybody having access and then directing the money towards that goal is really the foundation. And then all the other things that you mentioned. And I love the anecdote you told about Walkerton, because, when I think about it, too, like when I think about the stories I've read and what I've heard through interviews about it, I was also struck by just the kindness and community orientation of the people who were standing in that line, and how they talked about how everyone was so nice and supportive and held space for them when they needed to go to the bathroom or get the, person from the car who they were holding the space for, etc. And I think to me, when we think about hope, like that's what gives me hope, is that people in Canada really care about each other and care about their neighbors and want everybody else to have that access. They want access for themselves, but they also want it for other people. And yeah, I think that's the way forward, is to listen to them and design around what it is that they say. Any last thoughts you want to share with us, Danielle?
I'm just very heartened and excited that you're doing this work, Tara. I think it's incredible. And I know that there's a lot that we can learn from our international comparators, and you're going to be talking to lots of super smart people who can describe for us what gets done well in other systems. There's a lot that we can pick up and take from those places. But I also think, like you, I've traveled and seen other health systems and read about other health systems and spoken to experts in other countries. And actually, what you are describing about that community orientation and that view that the health system is a defining characteristic of what it means to be Canadian, actually quite unique. Even in health systems that do a better job of delivering on it than we do, of which there are more than a few, that commitment to the values is not shared in the same way, like as a core value of what it means as a national building concept. And I think that is special and needs to be honored. And it is maybe what we have to teach the world, actually. It's our contribution.
Yeah, it's what we can give to the world. I love that. Primary Focus was created by me, Dr. Tara Kiran, and is made possible by a grant from the St. Michael's Foundation. Miriam Dinesh is our research assistant, Seema Marwaha and Emily Holton are creative advisors, and our producer is Avery Moore-Kloss. Primary Focus is supported by a grant from the St. Michael's Foundation, and I'm supported as the Fidani Chair in Improvement and Innovation at the University of Toronto and as a scientist by the Departments of Family and Community Medicine at St. Michael's Hospital and the University of Toronto. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or visit our website, primaryfocus.ca. For more information on the Our Care Standard and the public's vision for a better primary care system, visit ourcare.ca. Okay, thank you so much for coming.
That was fun. Thank you.
I hope it was okay. I know you had to rush here from clinic, and yeah, it's always a million things happening, but I hope it was good.
You did a great job. You're an interviewer.
Yeah, I'm a little self-conscious about that right now.
No, you did amazing. Thank you. Okay, I gotta go. I'm of course late for my next meeting, but so great to chat with you. Thanks for including me.
Thanks, Danielle.
Okay, bye.
Bye. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. The views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.